Hello, everyone. My name is Blair Agero. I'm an orthopedic hand therapist based in Dubai, United Arab Emirates, and currently working in the rehabilitation department and perform in Mediclinic Parkview in Dubai. Now, before I go further, I would like to express my gratitude to Dr. Nikolai Karpinski for giving me this opportunity to be part of this momentous event. It is indeed an honor and a privilege to be with all of you today, at least virtually, to share my approach and clinical experience in the hand therapy of the athletic wrist post-open TFCC surgery. Now, my presentation aims to share the approach on how I treat athletes who had an open TFCC repair and also to share pointers on the clinically relevant patterns that have continually emerged in my treatments of high-performing athletes. Now, we all know that the triangular fibrocartilage complex, or the TFCC, is one of the more important structures in the wrist, whose main purposes are to stabilize the distal radioulnar joint and also to regulate forces that occurs in the wrist. Now, because of the complexity of the TFCC, it has been a deterrent as of late in having a single rehabilitation protocol. And if there are protocols, they are either not reported or are poorly documented. Now, there is a general practice post-open TFCC repair, which is to immobilize the patient in a Munster cast or splint for weeks, ranging from 3 to 6 weeks, or as determined by the hand surgeon prior to starting hand therapy. And this is just an illustration of the anatomy of the TFCC, wherein we have the ulnocarpal or articular disc, the ulnocarpal meniscus homologue, the ulnar collateral ligament, the ulnar carpal ligaments dorsal and volar, the radioulnar ligaments deep and superficial, and also the ECU tendon sheath or the sixth extensor tendon compartment. Now, we all are familiar with the Palmer classification of TFCC injury. Now, in my practice, most of the patients that I would see would fall into the type 1 category. And of course, we also have a more recent comprehensive classification of TFCC peripheral tears by Dr. Atsei over here. And when patients come to me for therapy, I normally, at any point in time, especially obviously in assessments, I would perform a battery of tests, such as the piano key test, the Ballotman test, the supination test, the push-off test, the Fovea test, your press and grinding test, and also the weight-bearing test at different points of time in the rehabilitation and as I deem as appropriate, of course. And we also know that to diagnose the TFCC tear, the gold standards would be arthroscopy and or MRI. However, clinical assessment with special test and an MRI would usually be sufficient. So here I present a case of a 24-year-old male acrobat who was diagnosed with a partial tear of TFCC and a complete tear of the LT ligament of the right wrist, as confirmed and examined by a hand surgeon through physical assessment in the clinic and confirmed with MRI. So he had an open surgical repair for both ligament ruptures within the week from the diagnosis in 2018, and then he was referred to my clinic for hand therapy within the first week post-surgery. So the way I manage athletes with post-open TFCC repair, within the first week, when they are referred to me, they would normally come in the back slab, and I would take that and would replace that with a wrist brace, which is up to the forearm. It would be used in the span of up to 6 weeks, sometimes less, sometimes more, depends. And then the hand therapy would start with in the first week post-surgery, we'd focus more on, of course, the wound care. Then we would work on the scar management, isometrics, intrinsic strengthening, extensor tendon reinforcement, proprioception, and then would also include progressive weight training within the first week. And then we start rotation of the forearm, the pronasupination, on the 4th week. And by the 8th or 9th week from the surgery, the patients are already engaged in their full workouts in the gym. And by the 12th week, they are normally discharged from my clinic and back into their occupation or their sports. Here you would see just a demonstration of an active rotation of the patient. And as I mentioned earlier, we start working on the intrinsics and strengthening while we're waiting for the wound to heal within the first couple of weeks. I also start with the active range of motion exercises and light wrist weight training in the first week. So one of the mainstay of my treatment, of course, is scar management. And in my scar management, I normally use silicone stickers. I mobilize the scar tissue, and I use the therapeutic ultrasound. And for stubborn scars, I sometimes use clinical dry needles in order to facilitate the detachment of the adhesions, which I find to be effective. And of course, we also do the proprioceptive exercises initially, and then we do it progressively with some resistance for the ulnar deviators. And I also perform it progressively in different planes of movement before I start challenging them dynamically. So what are the things to consider when working with athletes? And number one, in my practice, I've realized that we have to pay attention to the psycho-emotional aspect of the rehabilitation process, not only amongst athletes, but also in general for all of our patients, because it is indeed an important part that is often overlooked. Number two, the recovery rate. So every patient would have a different recovery rate from session to session. So we have to pay attention to that so that we can adjust our treatment intensity and accordingly. Number three, we also have to look at the teammates or the members of the team who are working with the athletes. So I have been fortunate enough to work with professional athletes who also have other professionals working with them, such as an in-house physiotherapist, a nutritionist, a gym instructor. So I have enlisted the assistance of all these other professionals in order to facilitate the recovery of the athlete. And number four is to always test and retest. So in my practice, I always do the tests, the battery of tests that I've mentioned earlier, in order to check the integrity of the TFCC before I engage the patient in the exercises. Also, if I want to introduce an exercise for that particular session, I do it both before and after the therapy sessions. So here you can see this video is actually very recent, which was sent to me by the patient. And obviously you can see that he has been lifting heavy weights, and he reported that he doesn't have any issues with his wrist post-operatively. Now, I have been applying this approach to non-professional athletes, and the demographics as of now is that I have treated over 100 patients with this approach from 2013 to 2021. I'm still updating the data from my previous facility, and they have all been diagnosed with partial or complete TFCC rupture. But the commonality is that all of them, regardless whether they're partially injured or it's a complete rupture of the TFCC, the approach has always been an open repair. There were more men in the population than women, and most of them were aged 30, between 30 and 45. And about 12% of them are actually professional athletes, and 64 are sports and gym enthusiasts. And the remaining 24% lives a sedentary lifestyle. So what are the limitations of this approach? Obviously, this approach has not been validated or tested in other facilities. It is also not for the general population. This approach has been a product of necessity because I had to work with athletes with very limited time frame for recovery, and they had to return back to their sports or their profession, such as the acrobat. It also requires a significant amount of exposure to surgically repair TFCC for you to develop the familiarity and also how to progress and how to moderate the progression of the treatment sessions. And here is the patient performing some of his routine exercises without any issues on the wrist that has had surgery. And that concludes my presentation. And thank you very much for your attention, everyone. And this is the patient again, the one on top. Thank you very much for your attention.